whenever you have a child who is limping, you need to assess him as a whole. Okay. So is it common? Yes, it is very common, and many times it is challenging because the child sometimes doesn't know how to express pain or the limitation of motion and which part of his body. It can be classified as painful and painless. In general, causes can be variable, can be benign, can be simple, can be malignant, can be serious. So you need to start, of course, with history, complete history, physical examination to reach the diagnosis. And the physical examination, it has to include the gait. It has to be general and specific for each joint. For the lower limb, foot and ankle, knee, hip, and spine, and of course thigh and or tibia and femur in between. Then you need to observe the gait carefully to know what is the type of the gait. It might give you a clue. So the gaits type, as we know, we have few types of the gait. We'll start with the antalgic gait. The antalgic gait, it is because of the child will have pain in his lower extremity or in the back, and it is actually the most common type of limping, and it is characterized by that the child will have a very short stance phase to make his steps very soft on the affected limb. So the stance phase will be very short, and it can be caused by any condition during the weight bearing in the lower extremity, or as we said, even in the spine or the sacroiliac joints. Next type of limping is the treadle limbic gait. It is observed whenever you have a functional weakness of the hip abductor muscles, either because it is paralyzed or because it is shortened. So during the stance phase, the hip abductor normally should be active to hold the pelvis, while if there is any abnormality in the hip abductors, it will not hold the pelvis, so the pelvis will tilt away from the affected side. We'll see it in the picture, while the child will compensate by leaning of his body over the affected hip. So as you see in this picture, the child on our left-hand side is a child standing on his right foot. The left foot is not touching the floor, so his right abductors are working, so it is preventing the pelvis from falling away from the right limb. Okay. While the child on the right side, he's standing on the right side, his right abductors is not functioning, so the pelvis did fall down away from the affected side. So his affected side is the right side. We don't know about the left side. Maybe if he stands on the left side, he can support himself. And as you see, his torso or his body is leaning to the right side, so over the affected side. So you will see it during walking or during standing. So the other type is the proximal muscle weakness gait, where the child will have a lack of hip extensor strength. He will walk with increased lordosis in order to maintain his upright position. And classically, whenever you examine him for the Gower sign, it will clear, or you will ask him to sit on the floor, and he will stand. He will not be able to stand right away. You will see him climbing with his upper limb on furniture around him, then on his body, on his knees, thighs, till he stands, because of the proximal muscle weakness. And from the lateral aspect, you will see the lordosis. Spastic gait, it will be caused if there is hypertonicity of his muscle and his activity will be imbalanced because of the muscle groups. The opponent muscle group, they will not be working in harmony, so they will be against each other. They will have a sustained activity of the gastrosoleus complex, which may cause the ankle equinus and toe walking. If there is DG, the patient may appear to be dragging the affected extremity to be a little bit slower than the normal side. Short limb gait, they will have asymmetry in the limb length, which is whenever it is more than 3.7 to 5.5%, it will be clear. If it is less than that, sometimes very difficult to get short limb gait, because the child will compensate by having a little bit plantar flexion or flexing the knee, which if you don't pay attention from both profile, sagittal and coronal, you might not see it. While if the shortening more than 3.7, you will see the short limb gait. So he need to keep, of course, he need to keep his pelvis leveled. So he will try to accommodate for this short limb gait as much as he can, unless it is difficult, too much difference between the limb. So now we'll go through the causes of the limping. Causes can be classified according to their pathology, and we'll take them one by one. So the first group is the inflammatory and infectious disorder. So one of the common causes of this group is the transient synovitis. So the transient synovitis, maybe it's the most common cause of the lower extremity pain, which is most likely responsible for limping due to irritable hip in young children. It is seen between age of 3 to 8 years, and it manifests by rapid onset of hip pain, limited range of motion, and limping within short time, usually less than within hours or a day. Often there is a history of previous I think my screen went off.
إيه حتى الصوت اختفى شوي دكتور.
اي ما جاني اتصال، ما طلع لكم اتصال.
لا.
طيب خليني يس تفضل. Irritable hip might be they might have a history of viral infection like upper respiratory tract infection before the incident. Septic arthritis should be ruled out in these cases. Okay. Treatment is mainly by bed rest, non-weight bearing, and use of non-steroidal anti-inflammatory drugs, and observation for any signs of septic arthritis. So the next serious thing is a septic arthritis, which require more urgent intervention because, as you know, the sequelae of septic arthritis can destroy the hip. It has to be differentiated from the transient synovitis, which both can cause limping of the lower limb and of the limping of the child. So due to the septic arthritis, the patient need to be admitted and investigated and treated, most likely surgically. So as you see, some of the sequelae of septic arthritis, the first X-ray, there was nothing really appear. Second, the head start resolved. Third, the head destroyed completely. So if it is unrecognized, untreated, it will be the hip will be destroyed. So they will progress to febrile illness. Then they need admission. On examination, the child will refuse to move his limb, not like in transit synovitis. Transit synovitis, they will have better motion. Some patient will present with very mild finding, especially if they present early or if they are partially treated. So you need to be careful. This brings us to the Kocher criteria for septic arthritis. Kocher, the original Kocher, it was they had an algorithm in 1999 to differentiate between septic arthritis and transit synovitis. So there was 4 clinical predictors, which is the history of the fever, the non-weight bearing, the ESR of at least 40 milliliter per hour, and white blood cells more than 12,000. If you have more than the predictor will be only 0.2% if you don't have any predictor. If you have one predictor, one of these 4, you will have 3% probability of septic arthritis. 2 of these, 40%. While if you have 30, the probability is 93%. 4, of course, it will be 99%. So we always tend to see 3 before we do aspiration. 2 depends on the case. You need to go back, and of course nowadays the CRB is added to the Kocher criteria from the European side, so it is like kind of modified Kocher. So it will add for you, especially in the second category if it is only 2 predictors. Joint aspiration is very important to reach the diagnosis and to identify the organism. Organisms are changing with time. Nowadays, the most common organism may be the Staph aureus, but still MRSA or community-acquired MRSA cannot be ruled out. Okay, so any organism can be aspiration. Whenever you have the white blood cells more than 80,000, it is diagnostic. As we said, children, if you have a special child like immune compromised or syndromatic, maybe you will lower your threshold. Like if it is 60, 70, you lean more towards septic arthritis. It's not like it has to be fixed number 80 and above. Lower cell count, sometimes even if the child partially treated, again it has to be taken at serious and diagnostic. Commonly, the synovial fluid culture will be positive unless the patient has taken antibiotic. طبعا this should not prevent us from starting antibiotic early. In the past, Kingilla kingi, one of the organisms which has grown for some time, but I'm not sure now. I think is not that common. So treatment is IV antibiotic, joint debridement, followed by oral antibiotic to preserve the joint. In younger children, with the hip spica, post debridement. Another cause of the inflammatory cause is osteomyelitis. So in toddler or children, the osteomyelitis, they might manifest with just localized swelling or pain, or pseudoparalysis sometimes, which is maybe associated with sudden onset of fever and status. And the older adolescent may be more indolent, where they can't tolerate pain, and unfortunately they might have a delay in the diagnosis of the hematogenous osteomyelitis. So you need to take care whenever you have any suspicion in the distal femur, proximal tibia, or in the shaft of the femur away from the joint. Don't forget the osteomyelitis. So evidence of deep localized soft tissue swelling is often one of the earliest radiological signs of osteomyelitis, which sometimes maybe you'll not be able to see it by X-ray. Sometimes you will see it. So if you have any suspicion, you need to go one step further by doing ultrasound or MRI. So destruction of the bone, unfortunately, is common in the metaphyseal area, and sometimes it is not appreciated till it is few days from the infection. Discitis, again, another cause of the inflammatory causes. Infection of the intervertebral disc may interfere with the normal gait. As the result, the child will have back pain, or only he will refuse walking. Although they might not be doesn't appear ill, but their ESR will be elevated approximately in 80% of the cases of discitis. So this is one of the significant investigation for that. If you have any suspicion for the back or limping ESR, don't forget to ask for it. Early on X-ray might be completely normal. So if you have any suspicion in your examination, tenderness, limited range of motion, you need to do next more invasive investigation like bone scan or MRI. If you can localize the tenderness and the pain and the limitation, MRI for sure better. But if you cannot localize it in young children, so bone scan is better to specify where is the area for you, then you further ask for more investigation. So the child with discitis or vertebral osteomyelitis should be treated with systemic antibiotic. Bed rest alone might be enough for these children. Brace or cast sometimes is needed for some children, especially if there is destruction or weakness of the bone, which you are worried it will destroy, and you want to prevent deformity. MRI shown to be the best to give you the diagnosis and to give you the different stages of the disease, and later on for comparison for follow-up if you need. Juvenile arthritis, post-articular juvenile arthritis, sometimes it can present in only a single joint, which you need to be careful. What happened? كذا راحت. Yeah. طيب. It can be, it is most common type of juvenile arthritis. Usually lead to mild limp in children around 2 years of age. It affects girls 4 times more than the boys. Lab test may be normal, like the white blood cells, ESR, or rheumatoid factor. All these may be normal. So keep it in your mind whenever you have a joint swelling without any signs of abnormal lab, patient's child is limping, joint is limited range of motion or hot, looks inflamed, but all signs are of the lab all normal, and he's able to walk, so you can't really fit Kocher criteria more than 1 or 2. So don't forget the juvenile arthritis. It's common in young children. Any joint can be involved. Either the foot is one of the common joints, foot and ankle, can be the hip, can be the knee. So this is one of the causes which you always need to remember. Then we'll move to the second category, which is the neurological. After the inflammatory, we'll do the neurological causes. So cerebral palsy, the gait disturbance in children with cerebral palsy is caused because of the spasticity of the muscle group or the balance problem. Severity of the limp depends on the degree of neurological involvement. If you have a severe degree, they will have more limping. The diagnostic challenge is in these children because of their previous diagnosis. sometimes either they are not diagnosed completely by cerebral palsy, mild presentation to find difficulty to find cases. You need to start with a thorough history and physical examination from prenatal, postnatal, and delivery till their growth, their development. All this will give you a clue on their development and on their motor development milestones. So the patient will have a limited range of motion of the joints of the lower limb, the ankle, the knee. You might see hyperreflexia, clonus, and in some degrees spastic, in some degrees of spastic gaits. Although the orthopedic might be the first to make the diagnosis of cerebral palsy, the patient parent should be referred to pediatric neurologist for further explanation of the cerebral palsy by itself and treatment of the underlying neurological cause if it is needed. Other neurological cause is muscular dystrophy. So gait disturbance caused by this uncommon condition are usually first noted in boys from 2 to 5 years of age. And the difficulty in this group that many of them, they will present with their child limping, but they will tell you the child was walking normal. Then he will get worse with time. Then they will, some of them even they remember the time. When he was 3, when he was 4, when he turned 4, he started to have weakness. So don't forget the muscular dystrophy. Clinical examination may demonstrate the proximal muscle weakness, as we said, the Gower sign, or the toe walking, or the excessive lordosis of the spine when they are standing and walking. All these are signs of muscular dystrophy. The third category is the anatomical disorders, which is causing the limp. Of course, the most common in our country is the DDH, either dysplasia or dislocation, and it will cause a painless limp. DDH, as we said, either dysplastic with subluxation or completely dislocated, dysplastic with complete dislocation. The child might have shortened lower extremity if it is complete dislocation. If it is subluxation, sometimes it is difficult to appreciate the shortening, and you have to do it while the child standing, while child lying to see the shortening, and they will have short limb gait, as we said, and local examination you can find the Galeazzi sign or the limited abduction. The difficulty comes in the bilaterals. As we mentioned in the previous lecture, you have to do the classic sign. If it is unilateral, the child, if it is actually bilateral, will cause a waddling gait, and the child will have excessive lumbar lordosis while he is walking, and his abductor large to the affected side will be clear. When the child is examined in the supine position, you will have the restricted abduction, and the Galeazzi sign will be very clear. X-ray is your tool here, and can be done whenever the child around 6, maybe 5 to 6 months. You can do X-ray, and you will verify the diagnosis of DDH, either subluxation or dislocation. In some individuals, the hip pain and limb secondary to hip dysplasia may not become clinically apparent till they are adolescent or even older. Sometimes even in their 20s, you will see them with the hip pain if it is only dysplasia. The diagnosis is confirmed by standing radiograph, supine radiograph. You might miss many things, especially in mild subluxation or mild dysplasias. DDH, left side, complete dislocation, will cause limping. That's again another DDH, which is neglected DDH because it is bilateral. One is worse than the other, so she stayed for a very long time waddling. Nobody noticed her pathology. Coxavara is another cause of limping because the congenital, it can be congenital or developmental. It is painless like the DDH. And when the patient is examined in supine position, both hips, abduction and hip rotation will be restricted because of the abnormal neck shaft angle. As you see in the X-ray, the right side coxavara, the abductor will be very short. So the abductors are, neurologically, they are normal, but because the GT is much higher, so the abductor will be short, so their function will be abnormal. And they will have the limping and like what you see in the frog leg position, there is no enough abduction because of the abnormal neck shaft angle. Leg calf birth disease is another cause of limping. So it's usually in age group of children from 4 to 12 years of age. It will be exacerbated by vigorous physical activity like playing or jumping, and will be alleviated by rest. Classically, people, they used to say leg calf, most of the children will present with painless limp, but it depends actually on the time you see the patient. If the patient had multiple like falling down or playing around, vigorous activity, he might present with pain. So pain is one of the presentation of leg calf birth disease. Don't forget that. And of course, limping. Limping will be in all children, either if there is pain or if there is no pain. Hip range of motion, and if it is advanced, for sure it will be clear. Sometimes early leg calf birth disease, the range of motion, there will be very slight loss of hip range of motion. So you need to examine both hips at the same time, compare each range of motion with the other side to see if there is any difference. Patient with more severe disease, they will have more loss of the range of motion, particularly the abduction and the internal rotation, and they will experience discomfort during passive range of motion. Later on, the disease will progress, and as we saw in the previous presentation, collapse, fragmentations, of the femoral epiphysis. So that's a case of leg calf birth disease on the left side. As you see, the fragmentation and the loss of the height on the lateral column. Another case of leg calf birth disease in different stage. Slipped capital femoral epiphysis, it's one of the causes of limping. It can occur acutely or gradually. It is usually in older age group, in boys from 12 to 15, in girls from 10 to 13 in general. On physical examination, they will have pain elicited by both active and passive motion, and there is loss of range of motion in internal rotation and abduction. So whenever you ask the child to flex, he will flex, and he will have obligatory external rotation and abduction. So you need to be careful in these cases. You don't want to start with passive motion at all. You'll ask him to move himself if he can. Good. If he cannot, you don't want to exacerbate his slippage. It can be stable or unstable according to the weight bearing. Unstable condition is similar to an acute fracture where they cannot move the limb at all, and they'll be lying, and the incidence of avascular necrosis is higher. Both hips should be examined because many of the cases they can present with bilateral or one pre-slip and one slip. There is significant percentage of bilateral affected hips. So that's one of the cases of slipped If you look carefully at the right side, there is abnormal inclined line, so there is right slip. On the left side, you need to be careful. You need to examine. You need to make sure there is no slippage in both view, in the AB and in the cross table lateral. And if there is any doubt, maybe you need to do something extra, like MRI, to see if there is any signs of pre-slip. So in the cross table position, that was done frog leg before she come to us. As you know, all of you, I like to always ask for cross table lateral to avoid exacerbating the slippage. So she has slippage on the right side, while the left side looks normal. Chondrolysis is another cause of limping. Chondrolysis is very uncommon hip disorder that is seen in more in African American, in girls more than in boys, adolescent age group from 12 to 14 years of age. It is idiopathic. There is no clear cause for it. It is frequently associated with scaphy as a complication of the scaphy, up to 8% the incident, but the exact cause is unknown. Can be even without scaphy. It can happen idiopathic without scaphy. The patient has an antalgic limp, so the stance phase will be short. Clinical examination usually will show limitation of the hip motion in all direction. Radiograph demonstrate osteopenia of the proximal femur with narrowing of the joint space compared to the contralateral side. Subchondral decubitus. Treatment is consistent of extended rest, non-weight bearing of the affected extremities, and exercises to improve and maintain the joint range of motion. That's a case of chondrolysis. It's not that clear, the x-rays, but if you look carefully for the joint space on the left side, you can see a joint space of minimum 2 millimeter. On the right side, the joint space is completely obliterated, and due to that, the hip position is externally rotated. The whole pelvis is tilted. Most likely, the child is not walking and not moving this limb. Osteochondritis dissecans, another cause of limping. This disorder most frequently seen in adolescent age group, and although the knee is the most common affected side, but it can happen in other joints like hip joint, ankle joint. It can be involved. Like in this case, this is osteochondritis of the knee, of the distal femur, medial condyle. If you look carefully, there is abnormal medial condyle. Discoid meniscus. Can we take 5 minutes break يا شباب معليش؟ Osteochondritis dissecans. Then we'll move to the discoid meniscus. This disorder of the lateral meniscus usually seen in children from 8 to 12 years of age. Sometimes even it can be presented earlier. I have like 4 or 5 cases. They all presented around 4 or 5 years of age with limping, abnormal gait, which will be noticed by parents, especially if the child is thin. It will be very easy for the parent to see the abnormality. Accompanying the limp, they might have intermittent swelling of the knee, inability to extend the joint fully, clicking sensation around the knee. The diagnostic test is the MRI, will show you the discoid meniscus and the degree of the discoid meniscus. Then accordingly you treat it. The toddler fracture in young children, spiral fracture of the tibia without associated fibular fracture may occur when there is a torsion type injury of the lower extremity. The important thing here, the initial radiograph might be completely normal. Sometimes maybe suspicion on the lateral or oblique views, but in many cases it will be completely normal. If you have any suspicion, you need to treat the child by a back slap, then repeated X-ray in 1 or 2 weeks will show some degree of periosteal new formation, bone new formation, which is diagnostic for the torsional spiral fracture. And these cases are sometimes is confusing with Ewing sarcoma. So history is very important. How long, when was the trauma, how was the type of the trauma? All this will guide you. Is it tumor or is it tumor? Is it fracture healing? Like in this case, there is some periosteal bone formation, which can be one of the differential is Ewing sarcoma for this onion skinning or subperiosteal bone formation. So history is very important here. Tarsal coalition is another cause of limping. So if it is cartilaginous in the hind foot in young children, sometimes it will ossify when they are older. And when they start to ossify, the clinical symptoms will be more clear and will appear more and more. While if it was fibrous or cartilaginous in young children, sometimes is not clear. As soon as it is ossified or become thicker, the symptoms will be more clear. Contractures of the peroneal muscles is common in these children, which will result in stiff, everted flat foot. That's an X-ray of tarsal coalition. The first X-ray, you can see calcaneonavicular tarsal coalition with prominent peaking, very small line in between, maybe thick fibrous, and the lower X-ray is post-resection of that coalition. And that is on CT scan, subtalar or calcaneo-talar coalition. You can see it on the CT clear if it is osseous. Overuse syndrome, most commonly affected joint is the knee, in which the patellar tendinitis or apophysitis of the tibial tubercle, the Osgood-Schlatter disease, will arise. It's usually in older children and adolescent age group. Clinically, it's easy to be diagnosed. Their physical activity, the repeated jumping or playing will result in repetitive loading of the lower extremity and stress fracture, sometimes either in the tibia or the fibula. Clinical examination during the acute phase, of the overuse injuries, the treatment consists of rest, ice, anti-inflammatory medication till the pain and the swelling goes away. Then for long-term alleviation of the symptoms, the patient need to change the activity, some equipment or the equipment which he's playing on, or the training program. One of the important things in Osgood-Schlatter disease is the quadriceps length. Most of these children, they will have very short quad because they are just past their growth spurt. So their quad will be short. So the quadriceps need stretching exercise. There are so many stretching exercise for the quad. Maybe one of the best one is to have the child prone position, then to ask him to bend his knees till he is able to touch his buttock by the heel, or while he's standing by doing extension of the hip and full flexion of the knee. All this will cause stretching and with time will decrease the tension over the tibial tuberosity, and they will heal. Limb length discrepancy. Gradually progressive limb length discrepancy may become clear between age of 4 to 10 years. To maintain the level of the pelvis and smooth gait, the child either he will to walk on the short limb, or he or she will flex the knee to equalize the pelvis. So sometimes it's very difficult to pick this sign. So you need to look carefully for these areas, and you need to look carefully for the pelvis. Is it leveled or not? So to determine by X-ray which part of the leg is responsible for the limb length discrepancy, standing film, long cassette need to be done for the entire lower extremity, and careful looking for the X-ray is very important to reveal the finding, like mild congenital short femur, or physical abnormality after remote infection, or mild fibrohemia. This need to be looking carefully for it. And while you ask for standing, you have to make sure that you tell the radiographer whenever they do standing to do shoe raise, or to make sure that the child is not bending his knee, otherwise the X-ray will not be accurate. Causes, another anatomical category is the neoplasm. In the limping child, children with tumors can present with limping. So the most primary bone tumors are detected before age 20, either young children or adolescents. Differential. They are often diagnosed on plain X-ray, but sometimes cases like leukemia or even sarcoma may be difficult to be recognized. Tumor involving the central nervous system can also cause child to limp. Leukemia is a very important one of the differential which you should always keep it in your mind. Sometimes you are the first physician who's going to diagnose acute leukemia. Why? Because it is the most common cancer in children younger than 16 years of age. The incidence peaking between 2 to 5 years of age. About 20% of the cases, the child will present with musculoskeletal complaint, and the patient may have painful limb, limited range of motion, and in many cases you find the child had an X-ray once and twice, or even 3 times without a diagnosis. So the clinical presentation, with exception of bruising, bleeding, and hepatosplenomegaly, may be similar to that of arthritis or cellulitis, or septic arthritis or osteomyelitis. So all these diagnoses, we always see them. You might see leukemia in the same presentation. So the bruising, bleeding, hepatosplenomegaly, all these are helpful in your clinical judgment and evaluation. Initial radiograph may be negative for anything. Sometimes you can see transverse zones of lucent metaphyseal band adjacent to the growth plate. Sometimes you will not see them. So whenever you have a suspicion of leukemia by history, or the child doesn't look healthy or look ill, while your examination doesn't go with septic arthritis or cellulitis or osteomyelitis, thinking in the blood disease. So CBC is very important. Hemoglobin electrophoresis again is one important things. And if you have any abnormality or suspicion, you always consult your colleagues in hematology. Osteodysteoma is a cause of limping. It's a benign form of bone-forming lesion. In general, it affects individuals less than 30 years. You might see it in children. The most common clinical manifestation of osteodysteoma is localized pain and limping. Most of them, the child will point where is the pain and causing his limp. X-ray may reveal a small lucent lesion or the nidus, which is a couple of millimeter in general, less than a centimeter, with a marked reactive sclerosis around it. If the initial radiograph is negative, so bone scan can be extremely helpful to show the uptake or the increased uptake. Then you can do a CT scan or MRI according to the size of the lesion. Sometimes you have to do both CT and MRI. Thank you. My reference was the Tajdian Pediatric Orthopedic.
الله يعطيكم العافية دكتور. شباب أحد عنده أسئلة؟ دكتور بعد إذنك عندي سؤال. لما يكون عندنا حالة يعني suspected between irritable hip and septic hip, الكحة criteria only 2 positive. يعني is it preferable to start الانتيبيوتيك ولا لا الأفضل ناخذ aspiration؟ أحيانا ما بتكون واضحة الصورة. أخاف لو ادينا انتيبيوتيك إنه يأثر على الكلتشر لاحقا مثلا، أو إن إحنا نعمل شيء invasive ما كان له داعي أصلا. فإيش رأيكم؟
هو طيب شوف، if you have only 2 زي ما قلنا probability is only is about 40%. So other things will help you. مثلا CRB، شوف CRB، لو CRB عالي this is more towards septic, so you better treat it as septic. Start antibiotic and take the patient urgently for surgery. In the past we used to say don't give antibiotic till you do the aspiration, but this is not right anymore. If you give antibiotic, you will decrease the load of the bacteria in the blood or in the joint, and it will help the child not to go in septic shock. Okay, so nothing against starting antibiotic if you reach the diagnosis and you decided to go for surgery. Okay, in young children you cannot do aspiration in the مثلا في الطوارئ, so they will go for OR in general, especially if it is hip. If it is other joints, sometimes aspiration is easy, so you can, so it will not really delay your decision of giving the antibiotic or doing the surgery, so you can do it if you have high suspicion clinically. It's not only by only 2 I will not do aspiration. No, if it is 2 and there is high suspicion, the child looks unhealthy, motion is not 100%, not completely full range of motion, there is some limitation, and there is explanation of this. مثلا let's say no, he received antibiotic or he received anti-inflammatory, or he is مثلا he has some sort of immune compromised disease, مثلا diabetes or any other cause, عارف. I think it will be safer to start antibiotic and treat him as septic arthritis. Yeah. تمام. Any other question شباب؟
أتوقع ما في أسئلة دكتور.
اوكي ممتاز، يلا بالتوفيق يا شباب.
الله يعطيكم العافية. شكرا. الله يعطيكم العافية. شكرا دكتور.
شكرا دكتور. عفوا.